Hi there, thanks very much. So I'm a medical sociologist from the University of Leicester, and in this session Charles and I are going to focus more particularly on measuring safety and aspects of quality, taking forward some of the themes that we've already heard this morning about what matters to patients. And I guess one of the biggest problems for most people who are involved in providing services is the challenge of knowing whether what they're providing is safe. And this is actually a problem with a pretty long history. We could usefully start perhaps in the 17th century when there was a latter-day Dr. Foster in the shape of Sir William Petty. And he began to look at mortality statistics from hospitals in London, in fact, as a way of establishing the size of the population. But he then also became interested in establishing the size of the population in Paris. And he found, somewhat to his horror, that one hospital in Paris seemed to have a much higher mortality rate than comparable hospitals also in Paris and in London, and caused something of a diplomatic incident when he wrote to the French ambassador to complain that 3,000 of those who died in this Parisian hospital had died not by natural necessity but by the evil administration of that hospital. So sort of early interest in mortality statistics as a way of figuring out whether your care was safe. And of course also a long-term interest in looking at measurement as a way of figuring out whether things are getting better. And again, this has a pretty long history. And again, a good example is our friend Ignaz Semmelweiss, who was able to figure out that his theory, at any rate, was that there was some kind of contamination occurring as doctors went from the mortuary to the ward, and that this was implicated in some way in puerperal fever. And in an early version of a statistical process control chart was able to show that if you got people to wash their hands before they approached patients, then you could achieve a very good outcome. So a very important role for measurement here in figuring out where we're helping to solve the problem. And if we move forward a little bit to the early part of the 20th century, Ernest Codman in Boston began to become very interested in how we really knew whether what we were providing for patients was having positive outcomes or not. He thought it was intolerable that essentially there was no accounting for the quality of patients' outcomes. So he began to pioneer the use of what he called end result charts, and some of what we've heard of this morning from Jean is in fact the continuing evolution of those ideas behind end result cards. Also linked to that idea of measuring and knowing how well we're doing is, of course, the Dartmouth Atlas, which was not so much interested at that point when it began in looking at outcomes of care as looking at variability in provision of different kinds of procedures, and was able to show that there were dramatic differences. Some of the early work was on tonsillectomies, dramatic differences between neighbouring counties in terms of rates of surgical intervention. And this was part of the questioning behind, well, when are we getting it right? Is it very high rates or very low rates? It's a very important role for measurement in this kind of task. And of course, we've now begun to use those ideas in the NHS. The NHS Atlas has been a revelation in terms of some of the data it's producing, showing again these massive variabilities in both outcomes and interventions. This is showing if you want to keep both of your feet and you have diabetes, you may be best off avoiding the southwest of England. But this is also improved as these data have become available and the targets for intervention become more visible. So I want to emphasize, and you'll see why I'm emphasizing this so strongly, that we can't do without measurement. It's really, really critical to the provision of safe, high-quality care. But I'm now going to talk through some of the challenges that attend these attempts at measurement. So this book, many of you will have seen. This in some ways could be seen as the ship that launched the patient safety movement in the US and was subsequently followed in the UK. And this quoted the often cited figure that between 44,000 and 98,000 preventable deaths occur each year in the US because of errors in medical care. Now, if you read the book, which I suspect an awful lot of people haven't in detail, you will see that these figures actually derive from one study conducted in the early 80s, and a second one conducted in 1992, and an awful lot has changed. So relying on these figures just in terms of what's going on in healthcare is probably a little dangerous anyway. But in fact, those figures are wildly different because it's so difficult to get a fix using the methodology that they were using, which was case note review. And basically, they've just extrapolated, done simple scale-ups. So we actually don't know what the number of preventable deaths is to this day. When I was in the US in September, there was a lot of talk about this paper, which had just appeared using the global trigger tool. And this said, hey, it's not even 100,000 deaths. We're looking at 200,000 deaths a year attributable to medical error in the US. So we've had, 15 years of the patient safety movement, and now you're telling us the figure is twice as high. If you actually, again, read the paper, what you see is that this is based on 4 previously published studies using the global trigger tool. And in fact, if you count the number of deaths reported in those 4 studies, there are 38. So you go from 38 deaths to an estimate of 210,000. And in fact, the phraseology used, it means that you can't even say that those deaths are attributable to medical error anyway. We actually don't know how many deaths are preventable. The GTT was not designed for this purpose, and studies in Denmark and elsewhere have shown that using the GTT is highly sensitive to a detection effect. Basically, different people come up with different estimates depending on how well they're trained, their experience in the procedures that they're using. This I think, is one of the better studies. Again, it's using case note review, and this estimated that about 5% of deaths in English hospitals are likely to be preventable. It also very importantly identified that many of those deaths, most of them are occurring in people who are older people, and many of them are not big-ticket patient safety incidents like wrong-side surgery, the kind of things we hear about in textbooks. They're actually related to issues of basic care, clinical monitoring, and so on. But it's certainly a very different figure from the ones that are often thrown about in terms of preventable deaths in healthcare. So we're having difficulty using preventability of death, if you like, as a measure of quality of care. Another option would be to use process measures, and this has many attractions widely discussed in the literature, but can be extremely dangerous because of the way in which it can fossilize particular kinds of practices as being good practices, and then they can subsequently turn out to be actually wrong. So the US, for example, was incentivizing very tight blood glucose control in patients being treated in ICU. It subsequently turned out that this is not a good thing to do because more patients die when you control their blood glucose very tightly. So using that as a process measure was unhelpful. And the March 2009 issue of Health Affairs essentially came to the conclusion that it was very difficult to demonstrate a relationship between conforming to quality guidelines and the impact on outcomes. So we could turn to looking at other ways of measuring quality, and the famous quotation around the time when incident reports when wrong-side surgery became a focus of attention about 15 years ago was that my granny could tell you how to sort out wrong-side surgery. But wrong-side surgery continues to occur every single day, and we still don't know how many actually happen. This is a figure on reported incidents of wrong-side surgery over 15 years. Looking at this, you have no idea whether it's going up, down, backwards, or forwards, because what it's probably showing is an artifact of reporting, that we're getting more incidents reported, not that there is an underlying change in the number of wrong-side surgeries. So incident reporting is not a good guide to quality of care because or safety, because we're unclear about many of the relationships. Data for improvement, increasingly used with many good consequences, but also difficult to use as a source of data about whether your hospital, your organisation, your service is safe and high quality, because as Jonathan Ben and other colleagues have identified, often the data that's collected as part of improvement projects has lots of quality problems itself, including insufficient data points, lack of sufficient baseline periods, changing samples and annotation strategies, and inadequate annotation, so hard to use for that purpose. It's also clear that there are lots of technical problems in trying to set up measurement systems and collecting data. We were very fortunate to be funded by the Health Foundation to do a study which included a focus on how intensive care units were collecting data on central line infections. And what we found in a piece published in Millbank Quarterly and a rather easier to read a document published earlier this year was that there were hugely variable practices in terms of how people set up their data collection systems, how they were interpreting definitions, and how they were reporting, which meant that you could not compare reliably performance, if you want to use that term, between one ICU and the next. And this wasn't because people were deliberately gaming or hiding anything. It was just technically quite difficult to set up these systems. So this leads us to a real problem, which is patients want to know, is this hospital safe? Is this organisation safe? Is this service safe? And it turns out to be really quite difficult to give them an answer. So in the US, there has been a real interest in rankings, a league table kind of thing. But if you go to the data and try to compare what's going on here, you find that different methodologies are giving you very different results. So Massachusetts General Hospital gets an A on the leapfrog table. It's ranked top by US News and World Report, but it gets 45 out of 100 on Consumer Reports. So as a patient, which one is right? The bottom 6 on the Consumer Reports ranking all got an A from leapfrog. Hard to know what's going on here. This study, published a couple of years ago, was only able to identify a small handful of consistently high-performing hospitals, and the authors concluded that even that may be a chance finding. So hard to know what's going on here. One UK hospital was rated as one of the 4 most improved hospitals in 2006 to 7. Based on the Health Commission's core indicators, it was provisionally rated as good in 2007 to 8. In November 2009, Dr. Foster's Good Hospital Guide identified this as one of the 5 most improved over the last 3 years and in the top 10 of the league tables for hospital standardised mortality rates. This hospital was described in February 2010 by Sir Robert Francis as appalling. This hospital was Mid-Staffordshire NHS Trust. So a lot of challenges in reading off what's going on by looking at certain kinds of measures. Sir Robert's inquiry concluded that some of the treatment of elderly people could properly be characterised as abuse of vulnerable persons. He was basing that on the stories that he got from patients themselves and very disturbing narratives that he got from people who came and told him what had happened to them. And I think this is one of the best observations on the Mid-Staffordshire debacle. This was actually a consultant in the hospital who said it soon became clear that the real position of the hospital in the National League of Awfulness did not matter. What did matter was that many patients had received poor care, and for some, their treatment was appalling. This paper that we published earlier this year, Culture and Behaviour in the English National Health Service, tried to tackle, among other things, this problem of how do boards know what's going on in their organisations? How would you know if things were beginning to go to the bad? And one of the things that we discovered is that the quality of intelligence, and I'm using that term very deliberately, is highly variable in terms of what's available to boards. The extent to which data are converted into actionable knowledge and then an effective response mounted is hugely variable. And what you see are behaviours that range from what we call problem sensing. So these are very active behaviours, out trying to figure out where are the problems, how can we fix them, through to comfort-seeking behaviours where data are being used to reassure, not to find out where the problems are, but to sort of comfort and to seek solace in the data rather than challenge. And what we concluded is that measurement done badly is worse than anything, and measurement acted on badly because it offers this illusion of control. People think they know what's going on, but in fact they have developed what we called blind sight. So you're looking at data, you think this is giving you an insight into what's going on, but you're actually blinded to the reality. So measurement done badly is very, very dangerous. A very important point I want to make is that measurement is not just describing what's going on. It's got properties of reactivity. The thing that you're measuring responds to the act of measurement. So it's not just a challenge of finding the right measures. It's not just that we haven't found the right measures yet. It's that measurement is acting back on what it describes. And this is beautifully described in the context of financial services by Donald Mackenzie's book, and I think this is a great phrase. The book is called An Engine, Not a Camera. It's not a camera. It's not simply taking a picture of what's going on. It's an engine. It's driving what's going to happen. And measurement in healthcare is often deliberately performative. It's deliberately being used in order to induce certain kinds of responses. And I think the challenge has been that we have been too attentive to what it's supposed to do and not attentive enough to what it's doing as well. So Goodhart's law, often quoted, any observed statistical regularity will tend to collapse once pressure is placed on it for control purposes, is demonstrated over and over again in a healthcare context. So measurement is discipline, right? Because organizations and individuals are orienting themselves to what is being measured. And this happens in all kinds of ways, both subtle and non-subtle. So a very aggressive manifestation of this is hard governance, when we tie rewards and penalties to performance. And maybe in the discussion I can give some examples of this. But also important are forms of self-governance. So basically people beginning to internalize what is valued about what I'm doing because it's being measured. And they may not even be conscious of this, but they come to see themselves in ways that are defined by the measures. And what also happens through measurement is you get these creation of status regimes. You get elites who emerge and losers, and the ways in which that then acts back is very, very performative. So a lot of the trusts that were in the KYO 14 are now having a lot of trouble recruiting. They can't get staff because they have become the losers in this status regime. And so that's an example of how it's not neutral simply to describe what's going on. Some effects of performance measurement that are extremely well described in the economics literature include effort substitution and gaming. And I'll just very briefly describe these because they're important effects. So effort substitution is when people direct their attention to what's being measured, which can be very good, but it happens at the expense of other valuable activities that aren't measured. So we've all seen this happen. You can certainly improve performance on the measure, but all sorts of other things start to go to the bad. Gaming has received quite a bit of attention, including in the political science literature, and again it actually has quite a long history. During the plague, if somebody died in your house, you were locked in for the next 30 days to avoid spreading the disease, and as you can imagine there was a bit of gaming going on as to where the body got counted. So once there is a consequence attached to what's being counted, you are likely to induce some kind of effort to respond to that in ways that make you look better. So I guess if I'm going to sum up what I'm saying, if you're not measuring, you're not managing. So I can't overemphasize the importance of measuring. If you're measuring stupidly, you're not managing. And if you're only measuring, you're not managing. And I'll just finish with a few further comments. The puzzle of, I really like this quotation. Michael Parr has written very widely on the performative effects of measurement and the ways in which we create what he calls rituals of verification. He's writing about audit in a financial context, but a lot of what he talks about is very directly applicable to healthcare. And I think this is a brilliant quotation, that the puzzlement of measurement is that numbers are powerful and fragile, simple and qualified, trusted and distrusted simultaneously. And I think that the challenge for us is how we recognize that and do something about it, capture what's good about measurement, but also understand where it can be dangerous. And I'll conclude by mentioning the challenge that not everything we need to know can be measured. So an awful lot of knowledge in organizations that's extremely valuable and that actually tells you where the concerns are, where you need to be worried, is highly fugitive in character. So it's fugitive because it's hard to get hold of. It may be hard to get hold of because it's so normalized it's now no longer visible. People have got used to it, like the fish don't see the water. This has become normal, and it's not until it's directly challenged or somebody disrupts it that you understand that this is not good. It's also fugitive because it may get lost in the noise of a lot of normal organizational moaning, but there are signals in there of things that really are deeply wrong and need to be the focus of serious concern. Some knowledge is going to be forbidden knowledge, so it's dangerous to know it and it's dangerous to tell anybody about it. And it may be dangerous purely at an interpersonal level, that if you tell someone that that surgeon is somebody you really need to be worried about, your job is on the line. So it may be very, very dangerous and threatening for people to reveal, but its quality as evidence may be highly uncertain. It may be in the form of gossip, it may be in the form of a kind of general feeling, it's an intuition, and it's very hard to turn into concrete fact. And it also may be fugitive because the people who know it have no means of making voice. So it may be that it's very vulnerable patients who are on wards, who can't speak, who can't articulate, who have no advocates, people who have disabilities or illnesses of kinds that mean that they can't articulate. That knowledge may mean that it remains very, very fugitive. So there's no, I think we can abandon the hunt for a single indicator that's going to tell you whether care is safe. That's not where we're going. We need to understand when we do measuring, it is performative. It is not neutral to measure. We need lots and lots of measures oriented towards problem sensing, but they can't just be measures, because we need other ways of getting to fugitive knowledge that isn't going to be about measurement, it's going to be about other ways of getting really fugitive knowledge. Thanks very much.